I am thrilled to welcome Dr. Barbara Chaiyachati with us today. She is a clinician scientist at the Children's Hospital of Philadelphia and the University of Pennsylvania. Her research portfolio includes a spectrum of work that addresses the biologic and lived trajectories after early life experiences of adversity, with particular drive toward identifying actionable points of intervention. Her interdisciplinary approach includes genomics, epigenomics, clinical and administrative data reflects the interconnectedness of health and lived experiences. And she integrates her action-oriented view to her clinical work as a founding leader within a clinical care track providing follow-up care for infants born substance exposed. Thank you.
Okay, and I'm the last thing but before lunch, so I will do my best. So thank you all so much for having me here today. I am so humbled to be considered a valued speaker to the Chosen Collaborative. You guys are really, from not being from Colorado, rock stars in terms of all of the work that you all have been doing for years in the organization that is already in place. And so I hope in the next few minutes to talk about a little bit of the work that I have been able to participate in at CHOP and UPenn, including the clinical care that we're delivering, as well as thinking about how, to the point of breaking down silos, how can we, from our space of perinatal care, participate and potentially lead some of that internal silo breaking that needs to happen to advance care across ages within our institutions. I do have some research funding. And so objectives, 3 big objectives today. 1, to reflect on the ways to support recovery-informed care, regardless of how we're providing it. Number 2, to describe one milieu and model of follow-up care, specifically to tell you a little bit more about the program that we've been able to build at Children's Hospital of Philadelphia. And 3, extend the work that we are all doing, recognizing that multifaceted needs of substance use disorder warrant a multifaceted response across the care systems that we participate in. So, recovery-informed care. I think this is a phrase that sits well with me, and yet I fully disclose that I'm not totally sure what it means. I want to show up to work and say, I am providing recovery-informed care, but I haven't found of my own self for my own textbooks a list of an answer that tells me, check, 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 you have done this. So I'm going to share with you all in an open and honest way some of the things that I think are important, and I trust that you all will give me feedback during lunch about how I can continue to improve this model. So when I think about recovery-informed care, I think of 3 key components. 1, compassionate care interactions. 2, knowing that recovery-informed care is relevant to the situation at hand, which is going to require a bit of content knowledge. And 3, recognition of that recovery journey. Substance use disorder is not the same as addiction, is not the same as recovery. All of these things have important specifics, and we need to be able to have some content knowledge around how these things interact. And I do this from a family vantage. I am, by training, a child abuse pediatrician. I came into the field of child abuse pediatrics from a space of recognizing that it is an uncomfortable and unfortunate reality that not all children live in healthy, stable, safe, nurturing environments. And my goal, my motivation, is to think about how can we support more children in order to be in a space of safety and stability. And so what can we do to prevent bad outcomes? When we recognize that substance use disorder, caregiver substance use, is every year the most or the second most common caregiver identified risk within national child maltreatment data, that from a child abuse pediatrician perspective is absolutely a place that feels like we need to dig in and think about what we can do better. And so how do I do compassionate care? Step 1, we have to identify that substance use disorder. But to identify substance use disorder, We need to have some sort of disclosure that this is relevant to the family in front of me. Ideally, we have that universal screening, and yet I think we all recognize that that disclosure is still going to happen in a situation where we have trust. Trust is harder when there is fear. Hence, compassionate care interactions are really the base of our care relationships and the ability to start this journey with our families in an effective way. And I've heard already this morning, and just lift this again to make sure that we are all on the same page with regards to the non-stigmatizing language that we are using. I have been continued to be moved by the language that I have heard in terms of the embrace of making sure that all of us are using person-first language and person-first language that is non-stigmatizing. And I think the really powerful thing about this is that this came from the AAP, right? We are here to break down silos because this is not an adult problem. This is a problem. This is something that is affecting our families and children. And so this is our emphasis added by me that we as pediatricians need to actively work to dismiss harmful stereotypes. And that includes the words that we use. And this figure, again, from the American Academy of Pediatrics, recognizes these green phrases as phrases that are better to be used, phrases that we should work towards using as we take away language that may be harmful or more stereotyping or stigmatizing to families. And while again, in this space, and as was talked about in one of the sessions I was able to attend this morning, I think I try really hard in my patient interactions to use this language. I try really hard in my patient care interactions, in my clinic rooms, in my hallways. I admit fully, I am still working on my bravery to step up in the restaurant, to step up on the street or the sidewalk, to interact with people outside of those situations where I know that I have the power to, in order to make sure that I am not only modeling this language in my clinical care, but that I'm modeling this language as a person in society and recognizing that this is the language that should be used every day, every time, not just in healthcare settings. But back to healthcare. Compassionate care, I think, also is important within the documentation and the words that we use within our medical records. So what does that mean? We absolutely need to have accuracy within our medical records. And yet, I think we also need to be very precise about the language that we use. And so one way that I incorporate that into my interactions with families is that I recognize that when I am writing in the patient's chart, this is baby's medical record. And I start my care interactions after my preamble and how are you and how's today and and then thankfully the computer is really obvious and awkward. And so I'm able to leverage that. And I say, you're going to see me typing information into this computer. Everything I type is going into baby's medical record. I know that baby's health and well-being is completely reliant right now on all of the care that you are providing. And so I'm going to be asking questions about you and your health and the home around this baby. If there's ever a time that I ask you a question that you think to yourself, no, ma'am, that is my information, not baby's information, just let me know so we can come up with a way to have that documented in the medical record in a way that is accurate and comfortable for both of us. A concrete example of how that has come to play is with regards to hepatitis C, especially for caregivers who experience a custody disruption. Having a problem list that says perinatal exposure to hepatitis C, I would argue, is equivalent to need for hepatitis C exposure monitoring with a note underneath that says screening indicated at. And then for those caregivers who have experienced custody disruption, the foster parent gets the problem list and the diagnosis list. They are not then being told directly that the caregiver has hepatitis C in their own medical record. And that was a solution that I was able to work through with one of the families that felt very important about that. This also reflects the unknowable future. We see a dyad in front of us, and we don't know what the trajectory of that dyad is going to be. And so just continuing to do what we can to be engaged with the family. Point 2, identification of substance use disorder. It is a medical diagnosis that I do not make. I am a pediatrician. And my part is to understand that there are aspects that are going to be relevant to the care interaction with infants. And there are some potential physical and neurodevelopmental manifestations of substance use disorder exposure in infancy. But to be clear, these things come with differential diagnoses, and these very much are epidemiologic associations with many confounds. There are no randomized controlled trials that are exposing pregnancies to certain substances at certain doses in certain times. And so we need to be sure that we are accurate about what we know and what we don't know. One sort of point of knowledge just to bring up for awareness is there are some novel reports of potential teratogenicity that in this report have been related to fentanyl exposure. I bring it up only because this was published from a group on the East Coast out by me, and this has come up. Some of the manifestations have come up as relevant within the population of children that I have the opportunity to serve. And so I don't know, I recognize that the content of substances is very different across geographies. And so I just bring that up in case, Philadelphia, the East Coast has been a place where xylazine and other adulterants have been very common. And I don't know where this is gonna, sort of suss out, but just a piece of knowledge to be aware of. And I think more commonly, the neurodevelopmental sort of manifestations really come up to the forefront. I think that the model put forth by Dr. Velez and Jansen is really, really helpful. And this speaks to, again, workshop content that was already covered this morning with regards to the potential components of neurobehavioral dysregulation that infants may manifest within the first weeks and months of life. Overall, autonomic control dysregulation, attention state control difficulties, motor tone control difficulties, sensory processing and modulation, and in general, an infant who just presents as very disorganized. But these differences are not happening in isolation. The environmental context that these infants are presenting with may very well be coming with a high stimulatory burden that may be further sort of exacerbating the changes that they may be at risk for to start with. And then to keep in mind that caregiver, when we think about it from a dyadic perspective, this is a dyad that may have altered response and reward processing. I am not a neuroscientist, and yet I think the data that recognizes that some of the same reward and response processing circuitry in the brain related to substance use disorder are those same pathways that are at play in those early bonding interactions with new infants. Data shows by fMRI that parenting brains with a history of substance use have muted responses to infant emotional cues. When I think back to my own postpartum periods and my process of being woken up every 2 to 3 hours overnight and simultaneously falling in love with the source of that sleep disruption, it is in many ways miraculous. All the ways miraculous. And so to think about what would that have been like if my brain wasn't experiencing a tightly evolutionarily controlled oxytocin dopamine surge pathway, I don't know. But I know that I am really grateful that my brain did. And so putting that in context, right, we continue to think about what are the content pieces that we need to be knowledgeable, and how do we present those context pieces to the families in front of us. Overall, infants may have increased tone. We know this. The odds ratio for torticollis, 4.32. And interventions, always pairing these things that we see with a potential intervention to support the family. To reiterate the model put forth by Velez and Jansen, overall, what this might look like, in addition to those physical manifestations, are that we have all of us sort of on a day-to-day basis cycle in and out of hyperarousal and hypoarousal. And the goal is that we're somewhere in the middle. In a dyadic care situation, the goal is that both bodies are in the middle, and that infant maternal bonding is happening when both bodies are appropriately regulated in order to be in that sweet spot. And caregivers with a history of substance use disorder seem to be at higher risk of oscillating quickly between states of hyperarousal and hypoarousal. The same is true of infants, who may be oscillating between states of hypertonic excessive crying, as well as being sort of worn out. And so what that might mean is that we end up with very little time of that Goldilocks and the three bears of both mom, caregiver, and baby in that nice sweet spot in the middle. So what can we do to support that is name it when we see it. Regardless of the care situation that we are engaging with families in, taking a pause, interrupting our own spiel of what it is we're delivering when we see those moments of dyadic regulation, naming it and lifting it, providing that dopamine surge to both baby and caregiver when they are co-regulated, regardless of what else is going on. And continuing to partner with families to support and identify opportunities for that regulation at home as well. Early intervention is here, continuing to think about early intervention, home visiting, other services that may be able to provide some of those same moments of positive feedback in the home environment. I'm checking time. Hold on. Okay, here we go. Endpoint number 3, recovery journey. So I said recovery-informed care is 3 parts: compassionate, content, and understanding a little bit of the recovery journey. And this schematic from addictionpolicy.org reflects that a recovery journey is that. It is a journey with many ups and downs and spots along the way. It's even more than that. And the point of this is that you can't read it, I can't either. It's really complicated. There are so many stops and starts. But if we go back to this, point number 2 is trigger events. And if you were to zoom in on here, one of the trigger events identified is Child Protective Services. And that has absolutely been shown in national data as well as narrative data, that Child Protective Services engagement, punitive responses, the fear of punitive responses is and can be a trigger for families in their substance use recovery journey. But to be clear, just as being trauma-informed does not abdicate our responsibility as mandatory reporters if a child is harmed by a traumatized caregiver, non-stigmatizing, recovery-informed care is not providing blanket acceptance of dangerous caregiver substance use that results in harm to a child. But it still pushes us to recognize substance use disorder as a medical diagnosis with the potential for recovery, not a moral failing that excludes us from parenting. And so what are my sort of like little moments of CPS considerations to keep in mind? I really like that hum. Thanks, guys. That was accuracy and testing interpretations. So I'm going to be very quick on this because we have another speaker this afternoon who will be talking more. But keeping in mind that when we test and when we have a result, that is interpreted in very specific and often substantial ways by non-medical providers in, for example, Child Protective Services. And so when we are a part of testing decisions and testing result interpretation and conveyance and communication, we need to be very accurate and provide the context for not only that a negative may not be negative. There are, in fact, studies that have shown that twins have discordant results. A positive may also not be positive. Fentanyl from an epidural can become fentanyl in a baby. And so we need to know those things, and we need to do our best to help others when testing when testing is appropriate or is indicated and happens, that we provide that context and that we engage in closed loop communication with Child Protective Services to support accurate interpretation of results. And so now I will very quickly describe one milieu and model of follow-up care. 15 minutes, here we go. Philadelphia so this is data adapted from the Centers for Disease Control. I'm here today from Philadelphia. This is unintentional overdose mortality rate in 2021 by large city counties. And Philadelphia is unfortunately at the top of this list. Put another way, this is data from Drexel University Urban Health Collaborative. These very small tech cities, Baltimore is at the top, Philadelphia is number 3, and Denver is down about in the middle. Finally, in case I hadn't convinced you that overdose is a substantial issue in Philadelphia, 1,413 overdose deaths in 2022 related to overdose. And the reason that I put this 516 is 516 represents the number of homicides in Philadelphia. All of these are unacceptable, unconscionable deaths. And yet, when I talk to my colleagues in Philadelphia, and when I talk to my neighbors in Philadelphia, that number 516 is much more at front of mind, is much more in the news, is much more, the things that are being talked about than the number 1,413. And so just thinking about that in and of itself as stigma from being unseen, I think continues to be part of my own process of trying to be brave and step up and continue to speak about this as an issue that warrants attention. And conveniently, or relatedly, the Southeastern Pennsylvania Community Health Needs Assessment, which is done collaboratively across multiple healthcare institutions as required by the Affordable Care Act, identified in 2019 and 2022 substance use as being one of the primary issues within our population. And so here's my story. In the summer of 2020, I was a fellow in child abuse pediatrics, serving infants and families in our foster care clinic. And I had some infants who had a history of substance exposure. And I called down the hall to the director of our neonatal follow-up program, or our NICU grad program. And I said, hey, Dr. Duncan, I have these infants. Should they be following up with you? They had prenatal substance exposure. They had NAS. Should they come down the hall? And she said, yes, absolutely. We see all of those babies. And she called me back 2 weeks later and she said, just kidding. Quality improvement, it turns out, had substantially a really effective non-pharmacologic quality improvement study had decreased the length of stay from an average of 30 days to approximately 13 days. And the associated referral criteria had maintained at 30 days to have follow-up within our neonatal follow-up program. And so we took a pause and we said, okay, well, is this something that we want to address? And we did a local landscape assessment, talked to a lot of people, recognized that we were not the first people in Philadelphia who had recognized this as an issue, recognized we were not the first people in the country who had recognized this as an issue. The AAP came out with guidance in the fall of 2020, and we were very fortunate and able to secure institutional funding, open up a clinic in February of 2021, and the day after I graduated from fellowship, open up a clinic called NFP-RISE, or Resilience After Infant Substance Exposure. This clinic has been built in collaboration with our adult addiction medicine providers. And so we've been able to incorporate lived experience expertise throughout our clinic building and process. We have care navigation through certified peer recovery specialists, as well as physical therapists, and have been expanding our referral system. What do? We are a subspecialty follow-up clinic that is distinct from primary care. We provide standardized neuro and developmental screenings in a multidisciplinary clinic with PT, OT, psychology, social work, MD, as well as care navigation, as I mentioned. And who do we see? We see any infant with prenatal substance exposure, either by screening or testing, And often this is operationalized by any infant who stays in the hospital for an extended period for eat, sleep, console monitoring. Our mantra is sort of, if we have come to the space as a medical team to say that we needed to change your birth hospital experience, then we feel like we owe those families one more visit at least to sort of wrap that up and see how they're doing. If there's any additional changes, any additional concerns, what could we do to help support that family in a follow-up setting once they're through that initial incredibly important point of connection at the birth hospital, but also a really overwhelming point with lots of people, lots of voices, lots of things going on. We see infants and children from birth up through age 5 across any family structure. And related to our operationalization of Eat, Sleep, Console, we serve families and children with a full spectrum of substance use and recovery, as well as prescription-related exposures, including as related to chronic pain. Our clinic visit includes standardized neurologic and developmental assessments, medical examination, parenting and attachment supports, as well as service connections. And in general, we see infants for the first time at around 6 weeks of age is our goal. That is, our goal is to sort of be after the medical home gets established, have infants get home, get connected, get settled, and then come and see us for at least a one-time visit where we are able to really partner, see what's going well, see what things haven't happened yet, follow up on that early intervention referral that happened in the hospital, see what we can do to continue to connect and serve and support that family. We then engage in shared decision-making with the families in terms of when and how we're continuing to see them in a cadence, with a cadence as frequent as every 3 to 4 months, 6 months, 9 months, and 12 months. And so what is the content that we're covering? These are some examples. And this is all content and area and topics that can and should and could and are covered by many different providers, including things like Safe Sleep. And I would propose that the care that we provide in our interactions, families sometimes convey that it's not the same content that they're getting elsewhere. So as a concrete example of what that means, right? Safe Sleep. Many people have received and given Safe Sleep guidance, and we all probably have some sort of spiel memorized around or have heard it over and over again. And we do that too, except just a little bit different. So safe sleep is always important. Sometimes sleep is different because you're just really exhausted or because other things are impacting your sleep, like medications. Sometimes people tell me their sleep is different when their dosing is being adjusted. You know your body best. If your sleep is altered, safe sleep for baby is even more important. If you're drifting off or feeling sleepy, be sure to put baby somewhere safe. And this content and sort of working with the families and working with my lived experience experts and working with my addiction medicine colleagues as adults is really where we came around this content. We're able to name and develop, how do we discuss dosing differences? How do we recognize that, many people do have increased methadone doses during their 3rd trimester. They may or may not want to discuss that and disclose where their dosing is, nor is it my part as the pediatrician. But I can discuss it in this way and give power back in that dyad to the caregiver who, again, truly knows their body best in order to develop their own insight and lift their insight in that care relationship to keep the baby safe. With regards to CPS involvement, my goal is always to just maintain transparency. I ask families about Child Protective Services involvement. I collect names and phone numbers if they have them. And I ask the family, what would you like me to share with them? Would you like to do a 3-way call right now? And the answer there is actually sometimes yes, that they want. And then we have that open transparency. I get to honestly say to them, I will only share with the caseworker the same things that I'm sharing with you. And while that is easy to say, and I think we all would, sort of adhere to that to whatever degree we can, I think families have a really hard time hearing that and trusting that. And so then when they are actually able to hear me say the things that I would have said otherwise, but I say them to them, with them in the room, it creates a level of transparency and trust that I think is really valuable. That does not make it easy. And three-way calls are not always the option. But I do have a family coming back to me in a couple of weeks where a disruption in care happened subsequent to our clinical care interaction. The caregiver knew everything that was happening. I was fully transparent throughout the entire interaction, and they're coming back. And that means a lot to me in terms of the value of being able to walk with the family through hard and unhappy spaces and continue to build that care alliance to recognize that we all have the infant's and child's development as our first number one priority. And we continue to evolve. We started small intentionally. We continue to be somewhat small, but I continue to hold premise that more can just be more. More is not always better. I do not want to be the extra thing on a family that is already stretched with bandwidth and requests and requirements and all of the things. And so I try to be very clear with families as well as with other involved parties in their lives to make sure that we are adding something, not just another to-do. We've also learned a lot of lessons in our process. We've learned flexibility, persistence, community, the importance of being connected to other people committed and doing the same work in order to learn what are the new resources, what is available, what's going on. And most importantly, I think we've really learned to prioritize service in the care that we provide. So when families say things to me like, I've been afraid to ask this question. Is the baby this way because of my substance use? That feels really powerful and really important to be able to partner and provide space for them to ask that question. When caregivers say, I completed my Child Protective Services mandated treatment program, but I'm still depressed and I need help, being able to be available in that space to provide that connection feels really meaningful in terms of the service we're able to provide. And finally, extend. We're going to break down the silos because we have to. We've been talking a lot about infants and children, but just to keep in mind, 1 in 8 children, it's estimated from data 10 years ago that 1 in 8 children in the US lived in a household with a caregiver who had a substance use disorder. And in 2022, the White House put out a really comprehensive national drug control strategy, which provided a lot of important and actionable suggestions to think about how complicated this problem is and all of the many ways and the many silos that need to be broken down in order to address this. However, there is absolutely still much more space and many opportunities to address children and families within such comprehensive policy work. And so, for example, harm reduction. I've heard already, right, the space of thinking about naloxone for children and families who are affected by substance use disorder, medication storage, as well as, sort of talking about safe sleep. I think those are all truly components of harm reduction that you all are talking about, but that were absent from the harm reduction sort of mantra that are often nationally put forward in terms of sort of adult-focused substance use missives. Treatment. There are programs that have been developed that specifically support and address some of the really difficult realities of those neurochemical differences, family-based recovery as one, that addresses not only the need for recovery and treatment among caregivers, but also simultaneously embed child safety and partnering with Child Protective Services when appropriate in order to really have a comprehensive treatment. And also identifying barriers unique to treatment access for caregivers, such as childcare. Criminal and legal system reform, family disruptions of any kind, including identifying when people are arrested and they are caregivers, that means their children may lose a caregiver. In addition, as we've talked about, punitive approaches from a child protective services lens continue to all be part, in my opinion, of the needed reforms we need to have a truly comprehensive national approach. And so what have we been doing locally? So that's like national stuff we could do. Locally, we have taken some of those things and we were able to build on the community health needs assessment in order to recognize that within our institution, some work that I will talk through in less than 2 minutes about thinking about how we can step out of our space in our pediatric care interactions, out of our space in our perinatal spaces, and extend into and potentially lead and guide some of the work that may be able to advance an opioid response system within your institutions or programs. So we have something called CORE, which is the Comprehensive Opioid Response and Education Program, which is housed within our Poison Control Center, part of our Center for Public Health Readiness and Response. And our core program infrastructure has 3 components: community education and support, pain assessment and management, and substance use disorder. These are some of the community education and support efforts that we have been able to put out. We have, oh, that flipped. We have installed drug take-back bins within our hospitals in order to facilitate safe drug disposal within our institutions. We have community naloxone distribution from our emergency room for any family. We have it on sort of rotating on the screensavers as well as within, on screens. So any family that presents to RED can ask for naloxone and take it home with them without any sort of intercalation into their medical record and from a prescription. We participate in community health clinics. We write policy lab and provide education within our system. Our pain assessment and management task force is our JCO sort of arm with regards to our opioid stewardship program. And over the fall, we initiated a naloxone co-prescription pilot. And we, in last summer, you can see, right, despite the fact that we were prescribing opioids from our pediatric institution, had basically no naloxone being prescribed. We made a BPA, and within 6 months, we reached approximately 50% of all opioid prescriptions at our institution are being partnered automatically with a naloxone co-prescription. An enterprise-wide rollout is coming soon. And finally, Substance Use Disorder Task Force has built an adolescent withdrawal management pathway, which is publicly available, and continues to recognize that substance use disorder is not just something for a single age group. It is not something for a single demographic. It is not something only for adult hospitals, but it is also something relevant to pediatric care. And this was a space of development and need that was identified, and I think is really important. Finally, our poison control colleagues have created educational content, which our providers were really hungry for as they sought to adhere to state licensing requirements and new DEA requirements. There's a lot of content available. A lot of the content is adult focused. And so partnering with some of those education content providers to create content that was pediatric focused satisfied a significant ask for our population of care providers. And so I've done all of these things, hopefully a little bit. And really the, sort of a take-home point being to recognize that our potential influence extends beyond our care interactions, that we all have the opportunity to contribute to the long-term well-being of children. Stigma is a barrier to healthcare engagement, and fear is a barrier to disclosing our vulnerabilities. I have a lot of colleagues who I would like to thank. And now it is time for lunch.
Questions? And I see Kelly back there with the mic. So we do have virtual participants. So please use the mic to pose questions. I'll get us started. So you highlighted that you are not the primary care pediatrician for these kids that you see. How do you work with the general pediatricians? One of the things that we have learned through our Chosen Quick Collaborative and surveying general pediatric offices, they feel pretty ill-equipped to take care of these kids. And while you address some of those things, they're still the front line for these children with perhaps some feeding issues, still some subtle withdrawal, questions around overall longer-term neurodevelopment. Just wondering how you've sought to support the general pediatricians within your community.
Yeah. Thank you. So a couple points. So one, we have provided some, just education. We have our conference and we're absolutely able to engage with our primary care providers that way. And then I'm just available. It's totally true. Pediatricians have questions. Families have questions. So just continuing to be available to our pediatricians and try to get kids in and to get infants in, to have that flexibility within my days and my schedules to say, what can I do to help? And being willing to just call and talk through the problems, talk through the challenges with either the pediatrician and or the families directly in terms of thinking about how can we troubleshoot and what can we do to sort of support you in this specific moment. It's lunchtime. Well, I really am so grateful for this opportunity. And I do really welcome, all of your expertise and input, in particular, as I think about, sort of this definition or idea of recovery-informed care. I think it is something that, again, I humbly try to go home at the end of the day and think I did well. And I would love to, continue to think about how I could actually define those boxes based upon all of the work that you all are doing as well.